Dr. Bill Adams here, and this is a No Spin Live special edition. I'm here with my usual experts, Dr. Charles Randquist from Stockholm, Sweden. Charles, how are you? Dr. Tom Wiener from just south of me in Houston, Texas. Tom?
Bill, doing well down here.
And last but not least, Dr. Dave Sieber from the first place to lock down in the United States, San Francisco, California. Dave, how are you?
Good. We're probably going to be the last one to open up, too.
Crazy. We're going to jump right into it. You know, I want to play a little clip. I'm going to start with you, Charles, because I want you to comment on Sweden. But I have a clip to show you. And this is from one of the scientists that we've been speaking about for the past 6 weeks. So this is Dr. John Ioannidis, who's a scientist and researcher.
Sweden was one of the countries that chose a less restrictive approach. It kept much of its society and of its economy open. It allowed most schools, kindergarten and elementary school and middle school to be open. It kept most shops open and bars and restaurants, although with some modest restrictions. It also allowed people to get together but not exceed a limit of 50 people. So in a way, it is very different compared to the draconian measures that were implemented with very fierce lockdown measures in other countries in Europe and in many places in the US. They have done fairly well. And of course, it is very difficult to compare one country against another because you expect to see large diversity in infection rates and also in death rates. A country like Norway, for example, where the average Norwegian is likely to see very few other people. It's very sparsely populated compared to Stockholm is not something that you can compare head to head. Maybe you can compare Sweden against Switzerland, for example, that had very draconian measures very early on, and the death rate per million population is slightly higher, a bit higher in Switzerland compared to Sweden until now.
Okay, so Charles, that's a lead-in, but Sweden has been really talked about, I think, even more in the past, 10 days, and there's a lot of this comparison. It seems like people are almost trying to, find where the flaw is, but tell us, you're there, give us the real story, what's going on in Sweden.
Yeah, no, it's interesting. Even the World Health Organization has changed its opinion. Now they're talking about Sweden like it might be a model how to behave in situations like this. Actually, the one responsible, Folkhälsoinstitutet, which is the department that advises the government, the one who's responsible for that actually wrote his thesis on pandemias and lockdowns. And in his study, he said there is absolutely no evidence-based medicine encouraging that type of behavior. So the world seems to be changing a little bit, and who would not, after 8 to 12 weeks in a draconian lockdown, not being able to walk outside your door with family members, 5, 6 in a 2-room apartment, who wouldn't go crazy? That's precisely what's happening. And where we do have data is actually showing that in depressions and in situations where families are confined, there is a higher rate of domestic violence, suicide, etc. We have evidence and medicine-based evidence on those things. So what we're seeing right now, because everyone has been comparing Sweden to other nations, because we are sort of unique right now, Japan has had a slightly similar approach, is that if you compare numbers with numbers, and that is a dilemma, as our colleague was referring to, there isn't a big difference. Now, where we've had a failure is that 50% of those, and we're approximately a little bit more than 3,000 death cases now in Sweden, 50% of those have died in elder homes. Now, the type of elderly homes we're talking about are not the ones where you normally would find elder people who are healthy. We're talking about the type of homes where they're really in a very bad situation. So statistically, they would already be very close or close to not being able to have more than 6 to probably 2 years left. And that's where we've really failed. We were not able to lock down those facilities. And there are many reasons for that. One might say that the type of staff that work in those facilities don't have the right education. The ones who were managing these type of homes were not knowledgeable enough how to proceed and not aware enough to take care of this. But facts are that more than 90% of those ones who have died in Sweden are 70 and above. 50% in these type of homes, 45% have been casualties in ICUs, and 5% have been 70 or younger. Life is as normal in Sweden right now. There isn't a big difference. We haven't changed anything. We're talking about sorry for this, Bill. Sorry.
No problem.
Give me 2 seconds.
Yep, no problem.
Let's go whack it. I wish I could understand Swedish.
You know,
He's yelling at his dog or something, probably.
I heard the dog come inside.
It's like,
Another
Sorry
COVID
for that.
mortality.
that'll be a good
Yeah.
outtake. Go ahead.
Yeah. Sorry for that. So the Swedish government right now is proceeding like they've been doing for the last couple of months, differentiating themselves from other countries, obviously. For the last month, people have been talking about herd immunity, and we're not sure where we are right now. The academic ones are talking about that we'll reach the so-called 40, maybe 50% level end of May. But we don't know, to be quite honest, because we haven't been testing. We've been testing staff in the hospitals, and we've seen numbers approximately that 25% have gone through the COVID-19 disease. But randomized studies in Stockholm area has showed around 10-15%. So right now, what the Swedish government is doing, encouraging, is having mass testing. We're starting to do that now, opening up. The reason why we haven't is because the quality of those tests, according to our government, has been insufficient in its specifics and significance. Now, the tests we are using right now are better quality, so that's why the government has chosen to do that. Another thing that's been brought up is comparing Sweden's death rate compared to our neighbors and other countries. The problem is we're comparing pears and apples here. Our situation is obviously, like you saw in the video, not the same as in Norway. I mean, their population is very different than ours. So when it comes to comparing those numbers, we've said this in all these shows that we've been running, we need to look at the numbers in a year. Then we'll truly know. Now, the problem right now is that anyone who dies in some countries are dying because of the COVID-19 disease. Even if they would be eaten by a white shark and they took that person out of the tummy and that patient was infected by the virus, they would call it death by COVID-19. And this is the problem right now with collecting the data. So the data we're seeing is, it is biased in some way. And I think the reason for it might even be to protect the kind of catastrophic scenarios that governments have been telling their citizens will happen if they don't go into isolation and quarantine and lockdowns. So truly, to be quite honest, comparing right now our numbers with other countries is not fair. at the end of the day, I do believe that we will have a lesser mortality rate than other countries. Why? Because our population is not depressed. We live in an environment where the economy is fairly okay, and there isn't a big budget deficit like in a lot of other countries. So, long story short, we're doing well, Bill.
Great stuff. So, Tom, I know you told us before that you pulled some really interesting data, and you've really been very good about that the past 6 weeks. So tell us what you found and what it means.
Well, along with what Charles said, it's important to understand where's this data coming from, how is it being used, and there's some real questions now. Now that we do have some data, its use in some aspects is questionable. One of the things that Charles just mentioned, that if you get hit by a truck, you're diagnosed with COVID. There is some actual reality to that. If you die in a hospital and intensive care unit, and actually to make this easiest, let me preface this by saying on April 14th, the CDC changed its methodology for recording COVID cases and COVID deaths. So they now include presumptive cases. So in other words, even with a negative test, if you had, for instance, a flu-like syndrome and you died of something else, then it is now listed as a COVID death. And that, to me, is an egregious error in recording and in statistics, because it is skewing the COVID death population and the COVID cases in a situation where you take the flu. The flu is very underreported. So the flu estimates, when we say that 51,000 people died in the U.S., last year from the flu, or 61,000, those are actually estimates because it's only taken from certain point study areas, study hospitals. So in other words, and we've heard, Bill and all of us have heard some doctors who have been taking care of patients in the hotspots say, I've never seen a flu patient in the ICU. Well, of course you haven't, because the flu is, to cause death, these viruses are leading into pneumonia. So what the doctors are seeing with the flu deaths every year are deaths by pneumonia. Most of those patients are not being tested for the flu, so it's listed as a pneumonia death. Now, everyone is tested for COVID. Everyone gets a COVID diagnosis. Now, even without a positive COVID test, it's a COVID death if it's a flu-like illness death. That is horrible statistics. And I can go in just a few minutes, or if you'd like me now, about more H1N1 data. But I think that that's really a big, huge key that we saw. We were seeing projections for a spike or a surge since mid-March and certainly early April, and it really, except for the hotspots, it didn't really happen. So then the CDC changed on April 14th its reporting methodology, and then we saw this uptick in cases and in deaths. That's where it's coming from. The cases were always going to increase because we're testing more. The deaths have been really fairly level, even in the hotspots, but this methodology is wrong. And jumping to Dr. Ioannidis, we just saw his video, and Dave, of course, has mentioned before the Santa Clara antibody study indicating that there's really a much higher incidence of the population exposed to COVID-19, that we're underestimating it by 50 to 85 times. Well, there have been many researchers and experts across the country saying that that's just bad data. Well, in reality, one of these kind of compilation of researchers were put together in an article on Ars Technica. And this was from these researchers, the ones against this data were from Columbia University, San Francisco, and from Harvard. So they were complaining that the data was being manipulated on this 50 to 85 times higher, and that this data was false. Well, if you look at how they proved it was so-called proved how it was so-called false, what they actually did was some very, very bad science. What they said was that they were estimating that the IgG test had a false positive rate of about 1.7%. The Santa Clara study indicated a 1.5% positive rate of infection in the population. So what they then said was that because the false positive in their mind is 1.7 and the number of positive cases in Santa Clara was 1.5, they took 1.7 minus 1.5 to mean that every potential positive case was a false positive. So what they failed to say was that's not 1.7% false positive, that's a 100% false positive rate. That is data manipulation.
That's really interesting. And back to your comment, Tom, you know, if you look at the deaths, I mean, right now I just looked at the thing we all have on our phone, the world meter, and there's 280,000 deaths worldwide of COVID, despite all this increase in reporting and everything we know about, and you just alluded to, but still 280,000 deaths versus, say, flu deaths are estimated at 670,000 per year. I mean, it just begs the question, like, obviously it was modeled incorrectly, but are the measures that are being taken and the other consequences worth it?
Well, and the best way to answer that question is, once again, as I've done in each one of the No Spin Lives, is to compare it to the flu. People, even researchers, don't want to compare it to the flu. They are determined to make this worse than the flu. The actual data shows otherwise, and this is from, and I will list the journals when I quote this. So let's look at the H1N1 flu, because this was a novel flu in 2009. The swine flu started in Mexico, and interestingly, it started in Mexico much earlier than what they initially thought. It was first detected in March of 2009. And this was, they thought that this was a late seasonal flu that was happening. The first two cases in the United States that were detected were April of 2009, Southern California. Okay, so the researchers then backtrack and estimated that the H1N flu actually started in September of 2008. So this flu was running around in the population for quite a while before it was detected, because it was hidden in the seasonal flu. And as a matter of fact, for instance, I found one statement by the UK Health Protection Agency. They stated that masks were unnecessary for the H1N1 flu, only in someone caring for someone who was sick. So that sets the stage for what was really worse, or are these really the same, H1N1 and COVID? So as we know, the H1N1 hit the younger population harder than the average flu, and certainly worse than COVID. The H1N1 flu, this is from Clinical Infectious Disease Journal in January 2011. H1N1 in the US had 61 million cases, 274,000 hospitalizations, and 12,500 deaths. Now, I'll focus on the deaths in just a second. 87% of the deaths were less than 65 years old. And the risk of hospitalization and death was 8 to 12 times greater in working adults compared to the seasonal flu. Adults 65 and older had an 81% lower risk of death compared to the seasonal flu. Now, the mortality rate for that older age group was actually higher, but because they had been vaccinated in the past or exposed in the past to an H1N1 type virus, for instance, the Spanish flu pandemic, they had antibodies. There was herd immunity. So there were another study, 18,000 lab-confirmed H1N1 deaths. The model actually estimated 123 to 203,000 deaths worldwide for April through December of 2009. That's not even 2010. That 18,600 lab confirmed deaths was worldwide WHO reported. 18,000? So the real estimate was 203,000. The seasonal flu, 19% of deaths are under 65 years old. And as we said, with the H1N1, 87% of the deaths were under 65 years old. So this was a global mortality that was similar to the seasonal flu, but it shifted to those under 65 years old. Interesting article, another one, and that data was from PLOS Medicine in 2013. New England Journal of Medicine in May of 2010, 20 to 30% of the H1N1 flu patients were asymptomatic. 20 to 30%. There's another reference that I've got regarding that confirms that. In Pittsburgh, after the second wave hit, the models indicated 21% of the population had been infected. So we're saying that the flu is not nearly as bad as COVID, but in reality, this data, this model shows that the transmissibility, the infectivity, the mortality overall of seasonal flu can be as bad or in some circumstances worse. The arguments are that there's a higher risk of stroke, higher risk of heart attack, higher risk of many other issues, when in reality the risks are highly similar to what has occurred with the flu and flu-like viruses. What these are problems of critical ill patients. And the data shows that this is very true, that in study out of the Journal of Clinical Virology, COVID-19, SARS, MERS all show clotting disorders, all in critically ill patients. For instance, there's a book, PPE for healthcare workers, and this was a technical book. The transmission of influenza A, because everyone is saying transmission of COVID is much greater. There was a study done on a 737 airliner that had been grounded. 49 patients were on the airliner. One patient had the flu. Within 72 hours, 72% of the passengers on that airliner were ill with the flu. That is a horrendous transmission rate. There was a second aircraft study listed in that book that also showed a 37% infection rate. So we're showing some significant transmission, significant issues. The European Respiratory Society had an article that showed an increased risk of stroke, MI with the flu, including under 65 years old, because those over 65 years old had a higher incidence of getting vaccinated. We're seeing the exact same things that are being argued that COVID is so bad. That was a long one, but that's it.
Yeah. That is exactly what our government and, of course, the advisors to our government predicted. Here in Sweden, this is considered like any other virus. It's a coronavirus, which we know affects the upper respiratory system more than other viruses. And that's the way we look at it. Now, the only reason why we do have limitations and we keep distance is because it is a new virus, a novel virus, in the sense we do not have an immunity, especially among those ones who are risk patients with risk factors. And the reasons why we're doing this is because we don't want our healthcare system to be overloaded. That's the only reason why we're doing this. So it's not because it's a plague. We're not creating a fear among our population citizens. We're telling them in a disciplined way, please behave, act accordingly in order not to overload the healthcare system. But people will die like with any other type of flu.
So,
yeah,
Bill,
that's go ahead, Tom.
Look, one thing, just to finish my long diatribe, was that the moral to the story is this: the H1N1 flu hit the under 65-year-old population much greater than the COVID. But we locked down, others locked down the world and the United States, locked down the economy, locked down functioning businesses completely for coronavirus. They didn't do that for H1N1, even though the working population was the susceptible population and the population that was dying on H1N1. And the UK didn't even advocate for masks during the entire pandemic. There's a huge disconnect.
Tom, but with the H1N1, the reason why the numbers were so low is because the elder and those ones who are risk patients had vaccinations that were similar to that virus.
Yeah. Correct.
If we would take those numbers into account, it would have been much worse than the COVID 19 is right now.
Exactly.
But bring back that to I think we're all aware of this, and I think people are getting more and more aware of that the lockdown and quarantine measurements have nothing to do with medicine.
Correct.
And that there are other factors, and maybe the future and time and history will tell us. But what we're seeing right now and the fear it injects into citizens is absolutely has got nothing to do with medicine.
Listening to Tom and Charles talk about the discrepancies in the data made me think back of when I was doing general surgery, and we'd have these trauma patients that would come in. They'd be post-surgical or trauma patients, and they'd be really, really sick. And oftentimes the patients, for whatever reason, would pass away. And you'd get a call from whoever was doing the death certificates, and they'd want to know, well, what's the cause of death? And if you said pneumonia, they'd say, you can't die from pneumonia. You need to come up with an actual reason that they died. So they made you be very specific about cardiac failure, respiratory failure. It had to be something that actually caused you to die. Now with all these changes, you can just say COVID, and that's an acceptable reason for death, even though it's probably caused by something else. A lot of those things may have been the cause of death, regardless of whether or not they had COVID. The second thing that I thought was really interesting is I read a study this morning about famotidine. And we all know that if you're on a ventilator in an ICU, you need to be on something for GI protection, right? And the study basically showed that people that received famotidine while in an ICU on a ventilator did better, which is strange because to me, all patients in an ICU on a ventilator should be on some sort of GI prophylaxis. So it kind of makes sense that the people who are getting better intensive unit care fared better than those who weren't getting proper medications during their time in the ICU. So there's a lot of data that's really missing from these facts that we're seeing, really skewing a reality for us.
Yeah, no doubt. So I just wanted to reemphasize something Charles said earlier, which was about how the scientists in Sweden don't consider this virus any different or any more dangerous than other viruses out there. There's 108 viruses out there, but that basically thought process is shared by at least 10 to 12 of the world's greatest and most well-known microbiologists and virologists and infectious disease doctors. We've talked about some of these in the past. I think that's an important point, and that's one that a lot of people just can't get past right now. But the truth is the truth, and I think that's what we've been talking about: science and data. Dave, I want to go back to you as well, because this is kind of segues into some of the things that both Tom and Charles have alluded to. Everybody in the world has heard this term, flatten the curve. Okay, flatten the curve. Everybody says it. But I think what we're seeing now, especially at least in the US, where we're starting to open up some, we're seeing a whole lot of people that are actually petrified and very fearful about going out because they still think that flattening the curve, which was originally conceptualized to decrease the peak and not overrun your healthcare system, has now been translated that flatten the curve translates to death and decreasing death and the whole outcome of the pandemic, which is not right. And I want to play, before you comment, I want to play a little segment from Dr. Ioannidis where he talks about this.
So if you look at what the proponents of flattening the curve theory have suggested, which is a very interesting theory and may well be correct, is that you do that not to save lives, but to postpone the epidemic wave, in a sense, to flatten the curve and allow you to gain time so as to be better prepared. For example, get more beds in place, get more ventilators, prepare your hospital for that major battle to be fought, prepare your testing capacity, get enough protective gear. You're buying time. But eventually, sooner or later, once you decide to remove the shelter-in-place situation, you're back to a virus that needs to spread, and it will spread, and it will infect the people that it didn't infect immediately, but it will infect them later, and you're just better prepared and with better capacity to deal with that.
Dave, tell us your thoughts about this, and what do people need to know about this whole discussion?
So I think what he said is absolutely correct. I mean, the whole point of this was to reduce the burden on hospitals. And I think from our standpoint here in the United States, that aside from the hotspots like New York City, where there's just so many people, I think the shelter in place did in fact flatten the curve and did not overwhelm the hospital. I can speak for here in California. I know that ventilators and ICU beds were never, ever a problem. If you look at the actual curves, without the shelter in place, it's more of a bell curve. When you do shelter in place, it just kind of drags everything out for a little bit more time. I think Sweden's model, where basically you're opening, we know what the high-risk populations are now, right? If you're older, if you have pre-existing medical conditions, then I think you still do need to socially isolate. The fear that's been created by the media is that we need to just stay inside and we can no longer live our normal lives, and that eventually the virus is just going to go away. Well, we've talked about that in the past, that it's going to be at least another 18 months before we even have a vaccination. And the virus isn't going to go anywhere. I mean, it's still here. So we just need to come up with, data-driven things to do so we can get back to normal life, get the economy going again, and kind of resume where we were before all this started.
So Charles, should people be scared to go outside?
Absolutely not. On the contrary, I've been saying this already 100 years ago. We learned from the Spanish flu that being outside is the best way to really take care of yourself and lessen the risk of having the virus. Sun and draft, fresh air is the best. And getting back to flattening the curve and quarantine and lockdowns, the concept is right. We have the same thing here in Sweden, but not in the draconic way that we've seen in the rest of the world. The lockdown should be, or the quarantine should be, for those ones who are risk patients and the elder ones. And that's where we, like most nations, definitely failed. But implementing this type for all citizens, young, taking them away from school, is absolutely wrong. And I think that's something which will be a awakening for a lot of people coming out, and there are no jobs. The economy is down the drain. And trust me, we've just seen the beginning of this. And we're implementing rules and regulations where we allow people to be surveilled in a way which would be totally unacceptable in any democracy. And we're herded like a flock of sheep. And that is really the sad thing with what's behind this, whatever caused this, because I still am in the dark. I do not understand. And I don't know if it's because if these measurements would have been implemented in Sweden, if the Swedish population would have reacted and said, no, I don't know if that's the reason why. But obviously, in general, people are accepting this. And for me, I do not understand how it's possible, because there's absolutely no proof that it has any effect. On the contrary, like I've said previously many times, I do believe it creates more death over time, not maybe due to COVID-19, the fact, but the consequences of the lockdowns, absolutely yes.
No doubt. And, Charles, you talked about this before, but more deaths, you can just compare it. I mean, I don't know if it's the World Hunger Organization, they estimated that there was going to be 130 million more people to die of starvation this year, just in 2020, from the trickle-down effect that happens from all this draconian stuff that's gone on. And unfortunately, numbers are numbers and people aren't just a number, but if there's 280,000 COVID deaths and you're talking about 130 million people, probably to which are children, under the age of 12 years old, I mean, that's not hard to understand the difference, right?
No. I'll tell you, my background is, my family is industry and we've been working all over the world. I'll just tell you a couple of things. When you look at it from above a little bit, we will see a big change within meat industry after this. I mean, we will definitely see a shift into more vegetarian type of meats. And I'll tell you, are you aware of, and there's a study done, do you know what type of working force is most affected by the COVID-19 disease, except those ones working in intensive care? Have you got any idea, guys? People who work with meat. And the reason for that is it's done in a cold environment with a lot of machines, and the meat industry is pretty big and they can't hear each other, and the way they're working, they need to communicate. It's actually the group that has the highest mortality rate among young people in any type of workforce. Now, that's just one example. We'll see things, the consequences, how we see and how we look at food. But you brought up the so-called third world. Due to the lockdowns, the transportations of food and animals, etc., will affect the world in general. I mean, the focus is no longer in trying to prevent other type of diseases in the way it used to be, or to serve those ones who will be in starvation, because the rest of the world hasn't changed. We've had these measurements here, but reality is that, for instance, in India, or let's go to Mexico City, 50% of the workforces, they live off salaries from that day. Those are facts. Now, of course, there will be consequences that so precede any type of mortality rates for COVID-19. And reality is, those ones who will die from these lockdowns and quarantines in these type of countries won't be people elder than 70. It's gonna be the kids, the young children who will starve to death. That is reality, and that will always be on our conscience, because we're the ones who implemented this.
No doubt. And so, Tom, just you can wrap up, but this whole thing, when you hear somebody say, I just don't feel comfortable about going to a restaurant, they're too scared to go out. What do you say to that?
Then they should never go out again, and they shouldn't have gone out in the past, because the flu is there. The 18 to 49-year-old age group is the least vaccinated, the highest risk for getting the flu, not the highest risk for dying, but the highest risk for getting the flu. And you're looking at a very similar, situation with COVID. It's for most people, COVID is very benign. Now, in the at-risk group, as Charles, as Dave, and as you have said, in the at-risk group, then it's like the at-risk group for the flu, which is very similar. And we have reports that come in. Patients who had and recovered from COVID are now getting are now infectious again, getting sick again, or testing positive again. Well, the World Health Organization on May the 7th finally stated that in reality that was a testing problem. What was being tested was viral particles that were being shed from the lung epithelium rather than live virus. So
Tom, can I make a comment on that?
Yes,
that came
sure.
from Korea, 167 patients, and we've been referring to Korea as one of these countries that has really been effective with the lockdowns. They opened up and now they're shutting down again. Today, actually, they took measurements to shut down again because they're saying we're getting hit by the second wave. And that's exactly what's going to happen all around the world. They're going to open up, and 3 weeks post opening up, things will happen. Suddenly people will die, and then the same fear. And this fear is the biggest enemy because it's so deep rooted now among normal. We are academic, we are doctors, we do know, but most people, they do not. And the worst thing that can hit you as an individual is fear. And fear creates also an aggressiveness in your behavior. So what we're seeing right now is more scary with this second, third, fourth wave, because that's exactly the behavior we'll see among governments. And
well, those additional waves were expected. You know, as the population gets back out, it was expected that there is going to be certainly an increase in case numbers and also even mortality, not to the same degree as early on, especially because this virus, you know, is transmitting fairly rapidly, and it's been here longer than what's thought. But you know, issues such as these patients, the World Health Organization itself said they are not getting reinfected. It was just a testing abnormality that occurred. Now we've heard about children getting this Kawasaki-like syndrome. And, you know, with that, if you look at the actual numbers, even worldwide, the numbers are extremely small. And if you look deep into the data, many of those children never test positive for COVID. So we're in a situation where, and Charles, as you said, that the population is prone to being scared. I would assert that there are many doctors and researchers who have that fear also. That's why we've seen some of these almost hysterical reporting of issues that just don't seem to pan out, and that this is so much worse than the flu. The data is clear that this is a very similar situation to the flu, and it will end up being a seasonal flu in the future after a vaccine and a treatment are developed.
And some of this, unfortunately, once again, is based on the type of news that we are receiving. Initially, we were told that 100 doctors have died in Italy treating these patients. But when you looked at the numbers, 85% were above 75 plus, heavy smokers treating these patients as GPs. So they would have been risk patients anyway. So, I mean, the thing is that it boils down to the fake news or miscommunication, or actually the news we're letting out in order to create something that has a purpose. So unfortunately, once again, I agree with you, Tom. It's strange that even some of our colleagues do not really read the science, but look at the news fed that we all are fed with, which
right.
Unfortunately is not very, very good always.
Yeah, news and social media, you know, and it's that's perception is reality, and unfortunately, most people's reality is inaccurate. It's not scientifically based. And the only thing I would add to what both y'all's comments on South Korea is I think South Korea, they did a very good job of containment of this disease because you know, their infrastructure and they're able to do it. They that's what they implemented. They did a great job of it. But in other places, including the United States, I'll quote Dr. Birx from the U.S. Task Force, the cat's out of the bag. We're past the containment phase. We're not going to contact trace. We're not going to contain the virus. It's already out, and there's nothing you can do. And the good news is just as you all have all alluded to, the virus is no different than other viruses we deal with all the time. And that's where the disconnect is. People think this is, you know, the bubonic plague, but it's not.
And maybe, Bill, it's actually the best that could have happened to the States, because those countries who have been successful, even more than South Korea, like Taiwan, is now the thing in Taiwan, they will be able to get those patients. But the problem in countries who've got the virus sort of quite widespread, but they still have the lockdown, the second, the third wave of it happens, is when they try to open up the industry, you don't go from 1 to 100 in opening up a facility that produces cars or whatever. It takes time. And then once you're up and running, they have to shut down again. And that will definitely hurt the economy much more than having the virus run over the country as a virus should.
Right. Okay, guys. So incredible comments and insights. Thanks so much. I appreciate you all's time. And we'll do it again soon as on the next episode of No Spin Live Special Edition. And you can see more of this on the plasticsurgerychannel.com.